Well, everybody agree that Asherman is the biggest nightmare for gynecologists. Going into a glued closed cavity with no identification for the direction is the biggest nightmare for every hysteroscopist. If you go wrong, you will find yourself going into a forced track and suddenly you are seeing abdominal structures and you're into the peritoneal cavity. So let's join together step by step and see how to overcome the challenge, how to draw the map, how to find your way. It's all about two arms: vision, tactile sensation. Tactile sensation means the feeling in your hands toward the resistance of the tissue. Stay into the cervical canal, give it time. I always say give it time. Time solves any problem. Fruits ripen by time. Wisdom built up by time. So give it time for the water jet to open the cervical canal, and the water jet will release the flimsy adhesions. So let the start be with the water. As let it be light, let it be the water to open the way, and then you can have some clues, some landmarks. This is the opening of the endocervical glands. Don't get confused. And the internal os is totally closed. So, what to do? Using the blade of the scissors as a retractor. Yes, look at this. Retractors. So, by fixing one blade and moving the other blade, this is the single action scissor, which will help you to push, retract the tissues, and then introduce the scissor gently to feel what is after, what is next. I call this technique the blind man stick, like the stick of a blind man, using it to probe and to feel what's after. So the greatest challenge is at the access. My famous statement, the success is in the access. If you go wrong, you continue wrong, you end wrong. So now gliding on the anterior wall, giving a chance for release of adhesions by combined scissor dissection. Yes, there's a little clue. I want everyone to join with me. The feeling of frustration, challenge, and victory. This black hole tells you that there is a cavity behind. But what cavity? Is it the uterine cavity or another bigger cavity? But the feeling that I am really going into the proper direction. Once you see this black hole, try to start to widen the size and glide slowly. This black shadow tells you about a cavity behind. It's a combination of scissor dissection, gentle push. Look at this. Using the blades of the scissor to elevate, retract, and dissect. Following your lead of this black hole. Yes, I can feel every one of you now. This is the most joyful moment when you realize that you are really entering the proper uterine cavity. So, this case is the true Asherman. What does it mean? Everybody believe or think that Asherman is intrauterine synechia. No. If you go to the original article of Joseph Asherman in the 40s, I think 1945, he described exactly what you see now. Ischial agglutination, ischial obstruction following difficult labor or following abortion. But intrauterine synechia, that we wrongly call it Asherman, is not described by Asherman. Anyway, we are now into the uterine cavity. Look at this big, thick adhesions on the lateral wall. The history of this patient, that she had a previous cesarean section. It was a complicated cesarean section with a lot of taking sutures in the lower segment, and ended in closure of the level of the internal os and the lower segment. Look at this. Yes, scissors are not only for cutting. What does it mean, talents? What does it mean, skills? Skills is not doing the same way that everybody is doing. Okay, you have to improvise. Everybody's using the scissor only to cut. When you play more with the scissor, you invent new ways. Scissors are used for so many actions other than cutting. And now we're inside the uterine cavity. So people ask me, so what was the menstrual history of this patient? According to classic Asherman, it is ismical adhesion with a reflex amenorrhea. So you can see that the endometrium looks very poor with a little patchy pinkish endometrial islands. So this patient has an amenorrhea and zero cavity at hysterography. Okay, these yellowish dots on the endometrium, people get confused. What is this? This is the effect of hormones. Patient received hormonal treatment in an attempt for withdrawal bleeding, but it's still amenorrhea. So I will leave you enjoy the procedure and come with more and more valuable practical tips. My beloved friends, whatever I learned in the years of my life, I squeeze it in a capsule and give it to you. Keep watching. So what I'm doing here is trying to probe and touch these two holes, which are assumingly the tubal ostium. But in some cases, this hole leads to another extension of the cavity. So how to know that this is the ostium or a lead to another higher up cavity? Just when you widen it, dilate it, and look at the lining. The endosalpinx is different than the endometrium. Another golden advice, listen. Sometimes you see this hole and you assume that there is still more cavity up above. You're not sure that this is the ostium. And you cut through this and then you perforate. So to identify the kind or the character of the tissue or the organ, you have to look exactly at the ostium and distinguish the endosalpinx from the endometrium. And now I'm giving attention to the big, thick, fibrous adhesion at the lateral wall. It actually starts these adhesions from the level of the internal os at the site of the cesarean section scar all the way up. It's the big, thick, fibrous adhesions. So observe the scissor movement, how to use the blade to elevate the tissues. Look what I say. Use one blade to stretch the tissues, stretch it, and then cut. Keep on watching. Now, mission accomplished, and we have a beautiful cavity. But for the sake to avoid reclosure or refusion of the adhesions again, it's preferably to insert a balloon or a barrier method. There are so many methods. You will see at the end of the video what are the rules and the guidelines from my point of view. IUCD hormones are good, but the balloon is, in my opinion, the best option. Insertion of the balloon under vision has a very important value, because if you insert the balloon blindly, it might get coiled inside and leads to improper filling. Also, inflation of the balloon blindly, you might put much more fluid, which keep the cavity of the uterus very distended, so the patient feel pain and she will remove it. But under vision, you can go slowly, and now you can see the coiling of the balloon. It's like a snake. So you can do under vision, pull up, straighten this coiled catheter to facilitate proper filling. So under vision, you can pull and straighten, and then you fill it with the proper amount of fluid, so it will not slip out and it will not be painful for the patient. It's better to trim the terminal part of the balloon, the part which is more kefaled to the balloon area, all right? So this will guarantee that the whole balloon will be filling and fitting inside the uterine cavity. Now, observe the beautiful step of pull on the shaft of the catheter to straighten this coiling of the catheter. Okay, so slowly pull, and you will see now a nice view of the catheter, straighten up, yes, properly positioned into the uterine cavity. And then you inflate under vision to know how much amount is enough. The usual questions, how many cc? There is no answer. It depends on the size of the cavity you could create. So now, push slowly the saline to inflate the balloon and make sure it's very well fitted inside the uterine cavity. This is how to inflate Foley's balloon after Asherman. I remind you again, this is the most important, most joyful step during Asherman surgery. Watch it.